at the International Brain Health Conference, which is the first one ever. And I think there'll be many more coming. I hope so.
That's the plan.
So this is our second day at the conference, and it's been going great so far. And looking forward to today's speakers. Today, I'm excited that I am fortunate enough to have been given generous time to talk to Professor Craig Ritchie, who is the founder and CEO of Brain Sciences Scotland.
Scottish Brain Sciences, yeah.
So Professor Craig Ritchie.
Thank you very much,
Welcome
Grant.
to the podcast.
Thank you so much. Thank you for inviting me.
Yeah. So I wanted to ask you about your background, because I know you're a medic, you're a medical doctor by profession.
Yeah.
Then you later did epidemiology for your master's. Then now you became a researcher interested in Alzheimer's disease and dementia, and you've done some remarkable work. And I think so far, when I was looking you up, there's so many stories told about you.
Hopefully some of them are good stories.
Well, there are lots of great stories. Looking at what you've done so far as an epidemiologist in this space, what has been the most fascinating thing that you've done?
Thanks very much, Grant. I think I graduated medical school in 91, from Aberdeen, and the whole world's out in front of you in terms of being a doctor. And I had some opportunities quite early in my career. Particularly when I did psychiatry. I trained in psychiatry actually in London at the Royal Free Hospital in UCL. But during that time, they had an exchange program with the Royal Melbourne Hospital in Australia. And I actually ended up spending about 4 years in Australia working both clinically with some really inspirational people who were, at that stage in the late 90s, were at the cutting edge of developing what we call memory clinics, because donepezil was launched and there was this new optimism around drug treatment for Alzheimer's. But the other half of my week was spent with a really inspirational guy called Professor Colin Masters. He's actually a neuropathologist, and in some ways he actually discovered amyloid way back in the 1980s. So already I had, as somebody in their late 20s, this notion of translational medicine. Yeah. Of how you are in the lab working at understanding the biology of a disease, and at the same time working in clinic, talking to patients and understanding their concerns. So when I came back to the UK in 2000, I got an MRC fellowship and I did, like you say, the epidemiological work. But I was always very interested in clinical trials. Yeah. And clinical trials at the end of the day are, whether it's pharmacological or non-pharmacological interventions, are about impact. It's about doing something to help that person get better, in effect. And what I was finding, as everybody knows, is that in the early noughties, and what everybody knows is that in the early noughties and, going into the 2010s, all the drug trials were failing. No new medicines were coming. When we launched donepezil, then there came galantamine, then there was rivastigmine. We thought this was going to be the golden age of drug treatment for Alzheimer's. And then it was tumbleweed for 20 years. And I think what we realized in that period was that we actually didn't understand the disease well enough to be treating it. And that's where I felt the laboratory scientists could work on animal studies, they could work in the lab on different processes. But what you really need to know is understand the disease in people. And that's where I then took my epidemiology, married it to the clinical trials, and did what we call translational epidemiology. Mm-hmm. And that is actually not just looking at epidemiological big databases, but actually cohort studies. Mm-hmm. In those cohort studies, I was privileged enough to lead the PREVENT study, EPAD, European Prevention of Alzheimer's Dementia study. And from that, we began to understand, dare say, a lot more about the disease. And also, clearly, the disease starts in midlife. Mm-hmm. And dementia is a very late-stage consequence. So the next step in that journey was actually to say, well, if this disease starts in midlife, are memory clinics seeing people with memory problems the right clinical setting? Or should we be finding ways to identify people and work with people in midlife who are at risk of getting dementia and they already have early disease? And that became Brain Health Scotland in 2019. But just to finish, so it's not an entire monologue, memory clinic that I ran in Melbourne in 1997, 98, and the memory clinic that I was running in Edinburgh in 2023 So what's that, 26 years? Nothing had changed. The drugs were the same. The prognosis was the same. Conversations were the same. The assessments were the same. And in fact, in some ways, in 2017, I'd actually argue the service was less good because we were discharging people. We were making a diagnosis and then we were abandoning them. Whereas a few years earlier, we were having follow-up and we were working with people through the journey. So I felt this disconnect between what we were offering clinically and what we knew scientifically was just getting wider and wider. And that's why I set up Scottish Brain Sciences, because I felt there needed to be a different place for that gap to close. Health systems, health services are under huge pressure. They're not a great place for innovation. They're not a great place for taking new ideas and embedding them in practice. So I felt what we need to do in Scottish Brain Science was in effect set up a new healthcare system that demonstrated the art of the possible.
That was the time when you left the NHS?
Correct. So that was 4 years ago now. Okay. And it wasn't as a criticism of the NHS. It wasn't to say to the universities or to the NHS or the public sector, you're useless. It was to say, look, you have other issues. You have other problems you're trying to solve. And innovating in Alzheimer's with monoclonal antibodies or blood taste biomarkers is impossible in a health system that's got a 2-year waiting list for a memory clinic. So what you said is, we have to recognize this. And we have to create another vehicle. We have to step outside and create another space. And in some ways, that's what IBHC is as well. It's a space for innovators. It's a space for innovators, not just to have ideas about what we should do differently, but do it. Actually make the change, make the impact. And also, as you're well aware, this is not a Scottish problem. This is a global problem. And that's why I'm so delighted there's so much representation from all over the world at this particular meeting. And that will be something we'll build on as the years go ahead.
Okay. So I know you became interested in early life diagnosis and prevention. So there's been lots of excitement around biomarkers, amyloid plaques, and other forgotten the Lewy body one. But
alpha-synuclein.
So in terms of like those biomarkers, if let's say as a young person I have an accumulation of amyloid or alpha-synuclein, are you then not risking, if let's say you're saying we need to be able to detect this risk early, are we not then creating a problem by risking overdiagnosis? Because a biomarker doesn't entail that you have the disease. But
I think that's a brilliant question. And it's probably more than just semantics, but what do we mean by diagnosis? Okay. So let me offer an analogy. Elevated cholesterol, hypercholesterolemia, hypertension, okay? Those in their own right aren't necessarily problematic. Unless it's very severe hypertension, it's not painful, it doesn't cause symptoms, then it's a risk factor for something else to happen in the future. Elevated cholesterol in its own right doesn't cause any problems. What it does is it increases the risk of stroke and heart disease in later life or years down the track. And I think what we're learning is amyloid in the brain is like that. Amyloid in the brain doesn't cause symptoms. What it does is it sets in motion various other pathologies which then cause symptoms. So from an epidemiological perspective, you would say that cholesterol, hypertension are probabilistic risk factors. They probably do something rather than what we call deterministic, which means they definitely will do something. Now, that's where I think it's not an overdiagnosis. You don't overdiagnose hypercholesterolemia. What you do is you try and find hypercholesterolemia because if you treat it with a statin or lifestyle interventions, you reduce the risk of stroke or heart disease in the future. Let's use that same analogy with amyloid in the brain, that if you treat the amyloid, then you're reducing the risk of dementia in the future. Okay, so this is actually a really important communication issue, because if I tested somebody for Alzheimer's pathology in their brain, cortical amyloidosis, with a blood test tomorrow, and I gave that result back, they would probably walk away and their default would be, oh my God, I've got dementia. That is not true.
I've been sentenced to death.
Yes, and that's a key issue with communication, with conferences, is getting that narrative accurate. The amyloid in the brain is not a death sentence. Now, from a biological perspective, if we talk about Alzheimer's, having amyloid in the brain then triggers the accumulation of the next protein called tau. Now, if you've got amyloid in the brain and tau, it almost becomes deterministic.
Yeah.
If you want to be really geeky about it, the hazard ratio between amyloid and dementia is about 2. The hazard ratio between amyloid and tau and dementia is 17. So you can see that the goal should be identifying these people with the earliest stages of disease and intervening. So if you can stop tau to accumulate, I think you could say you've cured Alzheimer's. But you won't do that in an elderly person who's got symptoms, because by then they've got multiple pathologies causing their symptoms.
Yeah. So then would it be accurate to say the only time a dementia or Alzheimer's diagnosis should be given is when a person has got symptom presentation?
Well, dementia, by definition, you need symptoms, you need functional impairment. I mean, dementia in some ways is a tough word. I don't like it. Okay, it's a clinical syndrome. It doesn't have any implications for what the disease pathology is, etiology. It just says that person sitting in front of me has memory impairment, one other function of cognitive impairment, plus it's having an impact on their day-to-day function. And in many ways, you could argue that is like, it's a palliative care stage of the disease. It's a bit like, can you imagine if we only ran services for people who had metastatic cancer rather than people who've got early stages of cancer? Can you imagine, an analogy I often use because my wife's an HIV physician at UCL, is can you imagine if we ran all of our service for people once they got AIDS?
Yeah, but when you think about it,
rather than when they have HIV.
But when you think about it again, what's the best alternative? Because all the time we've used expressions like dementia, and we say, okay, dementia doesn't sound so optimistic. Let's change it. But the only alternative that's currently popular is Alzheimer's disease.
Correct.
But it doesn't represent other types of.
Very good. Exactly, and I think that's I think what we need to do is we need to recognize our starting point is not the best starting point. So I think there's a lot of evolution of memory clinics and approaches of, changing the dementia diagnosis and adding in more biomarkers. I think what we need is revolution. I think what we need to do is we have to say, well, look, we understand that these diseases there's Alzheimer's disease, that's Alzheimer's pathology, there's alpha-synuclein disease, which can lead to Lewy body dementia or can lead to Parkinson's, disease. There's TDP-43 disease, which leads to things like frontotemporal dementias. We've actually started from the clinical syndrome and worked backwards. And what we should work, medicine, is about the biology and work forwards. And I think that's where this sort of brain health approach is actually got a kind of an open license to do things differently. And I think that's where, if you think about terminology, let's take Alzheimer's disease, you just use, again, traditional medical stage 1, stage 2, stage 3, stage 4, stage 5, like we do in cancer, stage 1, stage 2, stage 3, stage 4. And what we then do is say, well, look, okay, like in oncology, let's try and get people with stage 1 disease. Let's not wait. And if you have somebody with dementia, by the new NIH criteria, they really get stage 4 or stage 5 disease. And again, I come back to this. All of our clinical services today are about finding people with stage 4, stage 5 disease. Now, history, I don't think, is going to judge us very kindly. That we've stayed in that space where we could and should have been moving out of it for the last 10 or 15 years. So what I'm talking about today in my presentation is care pathways, is how do you actually take the science we have, the demands from the public, which are overwhelming, and set up a new care system. Okay,
so looking forward to your presentation. Then I wanted to find out, as a researcher who is an epidemiologist, is Alzheimer's disease the common type of dementia, or is the common cause of dementia?
Yeah, I think that's a brilliant question, because a lot of the epidemiology we have to date is saying that 60% of cases of dementia are due to Alzheimer's disease. But that's, again, looking through the wrong end of the telescope. It's looking at the number of people with a dementia syndrome and then trying to define it. And remember, we define it on clinical symptoms. We don't define it on biology. So it may actually be, as I think Jeff Cummings was talking about yesterday, that when you actually look at early pathways of disease in midlife, that Alzheimer's disease might be quite rare. Okay. Alpha-synucleinopathies might be quite rare in that early stages of the disease. What we have, of course, is the epidemiology being done in older people with a dementia syndrome or already cognitive symptoms. So we might find completely different things when we look at younger people in midlife and see what is the actual prevalence of cortical amyloidosis in that early stage. So, for instance, I mean, we do know if you look at studies like PREVENT or EPAD, and you look at the incidence of amyloidosis, it's actually less than 1% in midlife.
Yeah.
Brilliant. Let's find that 1%.
Yeah.
Because it ain't going to go away of its own nature. So this might not actually be a huge problem in terms of prevalence. It becomes a huge problem when you just let things go. And then aging and the impacts of aging increase the prevalence of the pathology.
So as a clinician, what's the one thing that you think, if it's not done now, makes you afraid of the future in the field?
So I think the one thing, I mean, this sounds a little bit cheesy. I think the one thing that if it's not done now is going to be a problem is we have to believe this is possible. Because I think at the moment there are so many people and so many institutions invested in the status quo that if we don't believe that this is possible, we ain't going to move forward. I mean, I've been sitting in senior academic positions. I've been an R&D director. I was deputy director of a clinical research network in Imperial. So I've been in the hot seat in some ways, but there's been no progress in 20 years. In fact, I'd say it's been going backwards. Yeah. My fingerprints are over that lack of progress. So I think one of the things is that people have to truly believe that this is possible.
Yeah.
It was George Harrison said that if you don't know where you're going, every road will take you there.
Yeah.
We need to know where we want to go, and we want to cure Alzheimer's disease. And if we're going to cure Alzheimer's disease, we're going to have to pick it up really early in midlife. Blood-based biomarkers, interventions with new pharmacologies are coming through, but gearing all of our science towards that prospect. Not palliation, not symptomatic benefit, not quality of life improvement, but cure. If we believe that, we'll do it.
Okay. So one question I also wanted to find out is, I know your offices at the
Murrayfield Stadium?
Stadium. Yeah. And basically what happens at your workplace? What do you do as Brain Science Scotland?
Yeah. And
why did you choose the stadium as your workplace?
So I mean, Scottish Brain Science has been in effect set up to, in a business sense, an entrepreneurial sense. You set up companies, you set up to identify, you identify a problem statement, and then you put in a value proposition to try and save it. The problem was that within the NHS and universities, there wasn't the ability to fulfill that belief that you could cure Alzheimer's. So we've created a new space. The problem is, how do you cure Alzheimer's disease? The value proposition is you do it in an organisation that has access to patients, to imaging facilities, to laboratory facilities, and we leave nothing to chance. We do it all internally within SBS, so that you can then demonstrate the art of the possible. You can have a package and say, look, we've done it. Not hypothetically, but you've actually, done what you said you were going to do. And the great thing about Scotland is it's a very small country. It's a great incubator. So you can do these things within Scotland. Why Murrayfield? Well, so we've talked about Alzheimer's, but people who play contact sport, be it soccer, NFL, rugby, are at very high risk of dementia in later life through another condition called CTE. And what I've been doing the last 5 years is working with Scottish Rugby to actually run brain health clinics for former professional rugby players, both men and women. And it's the same prospect. When people retire from playing international rugby or professional rugby or even community rugby, they don't have dementia, but they may be increased risk of dementia in 10, 15, 20 years' time. Yeah. Let's understand the biology of what happens after you retire and during the game, but principally after you retire, and see, can we intervene? Can we make a difference to the pathologies that build up that cause CTE and dementia? Of course we can. Yeah. But you need that data. You need that connection with. So that's why, why did I choose Murrayfield? I think Murrayfield chose me, to be honest, because Scottish Rugby is so invested in the welfare of both current and former players. So James Robson's talking here today, the former Chief Medical Officer of Scottish Rugby. So I think you'll understand when you listen to why we're working so closely together. Okay,
I'm looking forward to that. Do you play?
I used to.
Okay.
And I've had 5 concussions, by the way. So yeah, I've got a vested interest in this one. But I played way back in the 80s and 90s, and I think the game then was you got a head injury and you'd be back on again in the second half. You weren't necessarily protected, and I think that's one of the good things that's happening with rugby is it's recognizing its responsibilities for current player welfare. And I think there's whether it's if in doubt, sit them out, or the HIAs and what have you, we have to make the game as safe as possible.
Yeah.
But we also need to make sure we have the science to help with safety. I said at an interview once, we've got to science our way to safety. I think that's understanding what it is actually that is related to between the head injury and the risk of CT and dementia. One thing just to finish on this topic is that I'm always struck by the fact, if you play rugby or if you play football, you play any sport.
I used to play football.
Okay. If you got a knee injury, you would get physiotherapy, you might get some strapping, you might even need surgery. If you get a head injury, you get observed.
Yeah.
Why? Why don't we intervene? Why don't we do something immediately after the head injury? It could be an anti-inflammatory drug. It could be this thing that where you can cool the brain with something called polar cap, and that reduces the risk of inflammation and spit. So there's so many things that could be done rather than just observing people to wait till they get better. We actually intervene to change the course of the disease immediately after the concussion. That's what we're working on.
That's brilliant work. As Craig, so busy moving the wards and trying to create solutions. What keeps you excited when you're not working?
Oh, when I'm not working. What keeps me excited when I am working is amazing people around about me. I'm inspired by so many people. There's a lot of
Hope they're not your work colleagues.
They are my colleagues, my friends. I think this conference has actually got 250 people who share the vision, share the dream, share the appetite. So it's great to be in this setting. I'm glad I could play a part in making it happen. But I think it's just such a positive reinforcer when you hear the buzz and the conversations and what have you. Outside of work, it's beautiful family.
Yeah.
My daughter's here. She's a medical student. She asked a question yesterday. My son has just literally finished architecture here in Edinburgh. And my wife, as I mentioned, is professor of infectious diseases, and she's an inspiration as well. She is a proper doctor. And then I like hill walking, I like skiing, I like all those I love running. Keep it real. But yeah, it's getting balance. It's getting balance because that's good for brain health. You need your balance. You need your balance.
No, Professor Craig Ritchie, thank you very much for coming to the podcast today.
Really appreciate it. Thanks for the invitation, Grant. Okay.
All right. If you enjoyed this episode, don't forget to like, subscribe, and be able to share. And hopefully we see you next year at the 2nd International Brain Health Conference.